Well, thank you. Again, I feel really honored. So how I've laid this talk out is in 3 parts, and I would really like this to be very interactive. So if you have any questions along the way, please ask me, and or if you have any things that you're like, I just don't really agree with that, and this is the reason why, I'd love to have a conversation with you. So I used to be a hand therapist, so I specialized in the upper quadrant. I'm a certified hand therapist. I worked in an orthopedic surgical center. I would go into surgery with the doctors. I would treat them pre and post rehab, and I worked from the neck down, and it was all so interesting to me, and I loved it. But what I kept seeing is there was this revolving door of patients that would come through with upper extremity problems, and they would tell me about their other issues that were going on in their body, but they were seeing other practitioners for that. I started to question that maybe we're not treating the patients the right way by just looking at parts, and that maybe I need to go back to my textbooks and find out where I'm failing these patients because of this revolving door. And I wasn't finding what I was looking for in the textbooks. And so then I started to go and look at our anatomy and the way that we have set up our anatomy training. Now, our anatomy training is, we have to look kind of historically at it, of how we got to where we're at based on what we've known. And it really started with the separation of church and science. And so we're looking all the way back to Descartes in 1600s, that to really study the body in a way that we could go inside the body. There was a deal made with the church that we needed to separate the spirit from the body. Now, in the continuation of that is we started to understand that we could approach the system through a rational kind of approach, and that we could do it by going into the body and dissecting out parts of the body to try to understand it better. And so what it did is it created a system that we based our science around reductionistic thinking. And so that if we could look at these systems as separate from each other and study them in isolation, that perhaps we could start to understand them more. So that made a lot of sense, and it actually advanced science in so many different ways. And we started to have people like Borelli, who started to create textbooks of diagrams and pictures of what was inside the skin and what we could see, and how these organs worked and how these systems worked. Well, after he started to publish these textbooks, then we started to have other freethinkers start to look at the systems. And what they started to do is they started to look at the body like a machine and started to relate it to a machine. If we understand a machine, then we can understand the body better, and vice versa. So we had people that started to set up systems that we could look at the body like levers and pulleys. And we could start to understand that perhaps a joint is like a fulcrum, and that it has a muscle that when it pulls on it, it changes the length of the tissue. And so up until now, that's how we still learn anatomy. We learn that there's a skeleton, and then that there's these different pieces that go on it that propel the skeleton into different movement. And that has served us really, really well until we start to deal with situations like chronic pain epidemic, or we start to deal with autoimmune kinds of conditions, and then it starts to get kind of fuzzy on how are we helping these people, and are our interventions actually creating more systemic responses that maybe aren't serving the individual. So it's really exciting, because what happened in the early 19th century is we started to have osteopathy, the birth of osteopathy, and a bigger emergence in science around the understanding of connective tissue. And the connective tissue is a system that, in fact, when I went to school, and I think it is still happening today, that when we go into the anatomy labs, we're told to kind of cut away this connective tissue, this fascia, so we can understand the more important parts of the system. Is that how everybody learned anatomy and physiology? Well, the researchers have kind of turned it on its head and said, well, maybe we actually need to start understanding the connective tissue better, because then we'll understand the systems better. And when that happened, there was a real shift that's occurring in medicine today. And what we're starting to understand is we're starting to understand that it's not so much the isolated parts that are causing our system to function, but it's the relationship of the parts that are helping our systems function. And how can we understand the relationships better so we can understand how we can treat things better? Well, that's a really hard thing in allopathic medicine, because how we've set up our system has been that we've created specialists. And so specialists, like me, I'm a hand therapist. I specialized in the arm only. If you had a back problem, you go to the back specialist. If you have a foot problem, you go to the foot specialist. And any type of intervention that I'm doing on the arm will affect the rest of the system and vice versa. So we've had to really stop and look at this biomechanical model that's set up on this system of levers and pulleys and start to reevaluate that maybe there's a different way of looking at the system. We live in an exciting time because we're in an era that our science has really progressed, and we're able to look at real-time kinds of MRIs, functional MRIs. We're able to do a lot of imaging studies. We're able to start to merge concepts of Eastern medicine and Western medicine and neuroscience that is really informing us. And in the academic worlds, it's not filtering down as quickly as what's happening in the clinical world. So here in the clinical world, we've all been experimenting. We've been doing things like Reiki and craniosacral and other things, meditation practices, and recognizing the value and the importance and how you can really shift things. And so now it needs to go from the bottom back up to the top again to share that information. The exciting thing is it's happening. So now there are these international fascial congresses that are occurring, and they're congresses where there's researchers and clinicians that are coming together to share information about what we're learning about the importance of connective tissue. And what we're finding is pretty mind-blowing, and it is changing the way that many of us are practicing clinical medicine. Some of the research that's coming out around connective tissue or fascia is that it's a sense organ, and that it actually is helping inform our systems on how our body's operating from the inside out. And there's a lot of buzz, especially in the OT world right now, around interoception. And a lot of the fascial researchers are believing that it's the fascial system, which is the sensory system that's informing us about interoception. Our nervous system is embedded in the connective tissue, and we have these mechanoreceptors that are coming down from the central nervous system through the periphery that are sitting within the connective tissue system as well. And that relationship of the connective tissue system and the nervous system, there's a lot of parallels, but there's a lot of autonomy that's also happening in our ability to be able to understand where we are in space and our instincts, our intuitions, and that's something that we spend a lot of time about in Tensegrity medicine, is learning how to really listen to the inside of our body and the inside of our systems to lead us and inform us about how to relate in the external world. Now, I know a lot of you pediatric therapists are in the trenches of understanding how kids in our system are not, that's not valued in traditional settings. And so I applaud you in the importance of your work and helping children start to reconnect with themselves, because when that happens and we are helping adults connect with themselves, that's the way I think we can really change the world. So we have fascia that's really helping us understand things, and what it's telling us is it's not so important that we have muscles that do independent things, but that it's the connections of the fascia that are embedded within the muscle tissue and the patterns of organization of how the muscles are or chains that are set up of multiple muscles that help us create functional movement. So that's where in the movement world, in the training world, in the exercise world, it gets really interesting, because there's a big push right now around functional movement and functional exercise. And when we go into the laboratories now, what we're doing is we're dissecting without formaldehyde. And what we're seeing is, because the tissue's not dried out and there's no chemicals put in the body, it's just a body that has been either frozen or cooled, we can see this connective tissue and how it creates these what are called myofascial expansions that go through the system. So it's showing us in real time how my hip is directly connected to my shoulder in an actual tissue way, and how we have multiple connections to our systems that help organize our body to create patterns. So it's a different way of looking at the system when you're going to help somebody who's had any kind of disability, because instead of looking at the muscles and looking at the testing of the range of motion or the strength, instead you're looking at the patterns that have been organized through the systems, and how does that organism enfolded upon itself or created patterns around patterns around patterns. Now, the interesting thing with that is it's not just physical. What I continuously found in my clinical practice with patients is that there were belief systems and emotions and perceptions that were also tied to those stagnation patterns. And I couldn't continue to operate like those weren't existing and that I was just staying at a physical level. I recognized that when I helped the individual understand that their postural patterns were related to their internal ecosystem, and when they started to have an awareness and an understanding about that, that they could then start to choose different patterns in their internal ecosystem that could change their physical form. So it could kind of go either way. It was bi-directional. And so what I recognized is I started to need to add some dialoguing into my sessions that were about some of those beliefs and emotions. And so many of my patients would say things like, I feel like I'm getting a 2-for-1 therapy session while you're working on my physical body. And I said, well, it needs to go together for us to really make this transformational change and for it to really stay. So again, I think that our neuroscience and a lot of the understanding about psychology and somatics is really starting to merge now, and that won't seem like such a strange idea, I think, in 20, 30 years. So the other thing that we bring into this concept of Tensegrity medicine is around the understanding of our autonomic nervous system, and that's where I think Amy has a lot of expertise. But understanding that when a system is in a state of dysregulation and feels it's under threat, that it's really, really challenging to heal. So one of the primary components of our initial connection with our patients is to create a sense of safety and a sense of allowing their system to calm, so then the physiology can catch up and start to have more of a healing effect. And so I know with many of your practices, you probably do the same. And again, there's a lot of exciting research coming out about that. So basically, there's no movement that can take place in the physical body without there being a shifting of forces that are happening throughout the system. And so when I started to recognize that, I recognized that I could no longer be a hand therapist. I could no longer be cordoned to a certain point in the body, or as an OT, I couldn't just treat the upper body and leave the rest to the physical therapist. Instead, I needed to really be able to affect the whole system. And that anytime we have any kind of injury, if it's a physical surgical intervention, if it's a trauma, if it's a physical trauma or an emotional trauma, that can get stuck in the system as a form of a stagnation. And then what our body does brilliantly is it figures out how to create a compensation around that to help us continue to function. So a lot of times what we're seeing our patients for is they may show up with shoulder pain or mid-back pain, but we don't necessarily treat that region. What we do instead is we try to find the area of greatest restriction in the whole connective tissue system and treat that region, and often it'll allow there to be more give and resiliency through the rest of the system, and it'll resolve that shoulder problem. So an example I had is I had a nurse come to my office a couple years ago, and she had a frozen shoulder, and she had had multiple practitioners work on her, all different disciplines, and so I did my Tensegrity medicine evaluation, and I found out that her opposite hip was stuck. And so I said, well, you know, on your intake, you didn't mention anything about your hip. Do you have any problems? And she said, oh yeah, I've got a labral tear, but I can't really deal with that right now. I've got to deal with my frozen shoulder so I can get back to work. Well, I explained to her this whole concept that the whole body's connected, and these are the reasons and pathways that they are connected. and I treated her right hip, and her frozen shoulder resolved. So that happens every day in my clinic. And so I never go to necessarily where the pain is, but I go to where the greatest restriction is. But I always am addressing their pain complaints in some way, so they feel like, you know, I'm treating them in a way that I'm addressing why they came to see me. So in this training, I teach the students how to be able to assess the body, to be able to find those locations. Because in the connective tissue system, what is embedded within this fascial network are the cutaneous vessels, so the arterial and venous supply, you've got the nerve supplies, you've got the lymphatic system, and so all of those systems are going to be affected if there's any kind of stagnation in the connective tissue system. So we shape ourselves to fit the world, and by the world we are shaped again. And so this is a continuous process where our body's always shifting and changing. It's always adaptable. So whenever somebody comes into my office for any kind of treatment, what I recognize is that their system is whole and complete. There's nothing really to fix, and that their body's done a really brilliant job in learning how to compensate with these injuries and insults to the system until it can't anymore. And so what the body does is it'll run out of resiliency and it'll run out of adaptability. So my job as a practitioner is to give them more resiliency and adaptability in the system, that then they can actually have that discomfort become subclinical and eventually resolve on its own. So this is an example of a myokinetic chain. And so this is super interesting. This is the trapezius up here. So the muscle that sits up here on the top of the shoulder. And this is the deltoid that sits over the side of the shoulder. And then you can see the line, which is the intramuscular septum, and then that goes down into the forearm extensors. So in my dissection trainings, we can take this off as one continuous piece and recognize the continuity of the connective tissue fibers. Now, the scalpel is actually lying to us because it just depends on the anatomist and how they decide to cut through something to decide and call it a separate thing. But once I started to see these continuities through the system, then I recognized why I may need to treat a foot to affect a hip, or I may need to treat a hip to affect a carpal tunnel. And that's a game changer. That's a real shift in paradigm for our traditional treatments. So there are not, in fact, 600 muscles in the body, but a single connective tissue system that has pockets in it. And these pockets are filled in with things. So they're filled in with muscles, or they're filled in with tubes of blood vessels or nerves, or they're filled in with periosteum that are creating the bones. And so each of these pockets that has its specialized function is actually just part of a whole unit. So just to understand things a little bit better with connective tissue and fascia, the fascia is made up of cells, and so most of the cells are made up of fibroblasts. That's kind of the most prolific cell in the body. But the cells react to stretch of compression or distraction forces and torque and shear. So that's the biggest exciting area of research in connective tissue right now, is understanding that the way that the cell is going to express themselves is due to the extracellular matrix that they live in, the environment that the cell is embedded in. So whatever's happening in the environment is determining how that cell is expressing itself. I'm sorry. And if we don't have an environment that is healthy, just like if we don't have an environment that's healthy, then that cell is never going to be as functional and as optimal as it can be. We have fibers. So the fibers that are in our system are collagen. We have 28 different types of collagen. And collagen, the most prolific type in the connective tissue system, is really strong. So it's as strong as steel would be. So it's very adherent, and it allows us to be the form that we are. We also have elastin in our system, and that elastin allows us to have flexibility. So in certain parts of our body, we have more collagen than we have elastin. So on the side of my body where my IT band is, we have a lot more collagen, so it's made to be rigid to help us be bipedal and upright in gravity. And in other areas, we have more elasticity. And both of those things will be changed and altered, as well as the rest of the connective tissue system, when we have any kind of inflammatory processes that are occurring and there's any kind of postural dysfunction in the system. So the third component is this ground substance. Now, it is kind of the soupy, viscous nature of our connective tissue. And within the ground substance, we have all different kinds of components that are proteins and GAGs, glycoaminoglycans. We have proteoglycans, and all of these different types of proteins are serving a particular purpose. There's one in particular that's called hyaluronic acid that is getting a lot of press, and I see it in cosmetic products now, which I find kind of funny. But the hyaluronic acid is what allows the connective tissue to glide and to slide, and that is what is shifted a lot with a lot of the dysfunctions that we see in our clinics. So if you don't have the right viscosity of your hyaluronic acid, you can start to get adherence. And whenever you get adherence, you can start to get the nerve endings irritated, and those nerve endings that are irritated will become more what are called nociceptive in nature. They'll start to become more pain receptors than what their original job was. So there's a lot of theories now that a lot of myofascial pain syndromes and a lot of the chronic pain that we're seeing is related to the change of hyaluronic acid and the ability for these connective tissue systems to glide on each other. So what we're doing in our Tensegrity medicine methodology is we are looking at the assessment of the system and trying to free the bags of connective tissue from the surrounding bags and get these layers of connective tissues to be able to glide more freely. And we do that by performing different kinds of manual therapy techniques, as well as kind of movement strategies and dialoguing along the way. So this model of biomechanics is the one that was based on our old anatomy of looking at levers and pulleys and looking at fulcrums. And there's a new method or model that has been proposed in the last 30 to 40 years that's called the Tensegrity model, Tensegrity. It's based on the concepts of Buckminster Fuller and Kenneth Snelson. So if we, I didn't make my little model I usually have, but what it's made up, what the concept is that we're looking at the relationship of tension and compression in the system. And we have what I would consider a skeleton that is floating in a connective tissue system, and its position is based on the soft tissue and its tension or its compression that's being placed on the bones in the system. So that would mean that if we have the bones that are pulled too far apart because there's too much tension on either end or on one side, that you could start to have some changes in the joint itself, or you can start to have some bone changes or some structural changes of the tendons that go to those places. And we could put diagnosis on them, like tendinitises, bursitis, inflammatory kinds of conditions. Or if we have bones that are being pulled too close together, then we can have things like arthritis or disc disease or loss of cartilage formation. So instead of treating what the diagnosis is, the victim is, we instead can start to look at where the tension compression system, what's happening in the tension compression system through the global structure, and change that, and then we can restore the normal positioning of the bones that are floating in the connective tissue. So what do you guys think about that? Does that make sense, or are you like, what is she talking about? Well, this is probably one of the biggest changes in my life is when I saw this picture, and I started to understand that if I have this tension and compression system happening somewhere else in the system, so this, for instance, is the wrist, that it's dependent upon the tension and compression that's happening up in the shoulder. And that is dependent on what's happening in the rest of the system. So we can start to think about this tensegrity concept and look at it from a micro level. So we can even go down to the cellular level. There's a lot of cell biologists that are studying tensegrity now and looking at tension and compression of the cell. And then we can look at it at the macro level. What's happening in my global structure that's creating tension and compression. And then we can even take it out further and look at how our systems are impacting the environment and vice versa. So it's a very interesting theory. The person who developed it his name is Stephen Levin, and he's an orthopedic surgeon. I think he's based in North Carolina, or was. And he started to look at spines and noticed that they're not stacked up on columns like the old biomechanical model stated, but instead they're actually floating tension and compression. And it is the structures of the ligaments and the structures of the muscles themselves and the discs that are helping create these spaces between the vertebrae. So in the tensegrity medicine model, I look at that from a whole body perspective. And I start to look at the analysis of the whole system from the tension compression. And what we're finding, the scientists that are looking at this are finding that when there's this tension and compression forces that are placed on the system, that there's electrical and chemical changes that are happening at the cellular level because there's different signaling that's occurring because of the tension and compression of the cells. And so what we used to think was happening in the nervous system as far as communication and regulation of the system, we're actually starting to understand that perhaps it's actually happening in the fascial network. And again, knowing that the fascial network is the organ of perception and the organ of sensation, that's really exciting for us because there's other research that is talking about how we can change chronic pain patterns by bringing awareness to certain areas and doing interoceptive exercises. And we can shift, I think, lots of different patterns in the system by doing those kinds of things. So there's 3 different laws about tensegrity that it's a continuous connected tension network that's supporting these discontinuous struts. So you can see that these bars are never touching each other, but they're suspended in space by these cables. So this is at the Smithsonian Institute in Washington, D.C. It's a sculpture by Kenneth Nelson, an outside sculpture. And that I was standing underneath this, so it's called the Needle Tower. It's number of stories tall. And that if I pull on one cable, the whole structure would undulate. And so that was a really helpful representation for me of kind of understanding the body and how we can work with it. It's self-supporting and pre-stressed, so we're born with tone. All of you pediatric OTs know this, that we are born with a certain level of tone, and then it's when those tonal changes get altered that we'll start to have dysregulation in the system. We also know that we're independent of gravity, so we can stand on our head or do a handstand and that we're not going to ooze out. We're actually going to retain our form. And that it's self-contained, so all the components are dynamically linked. What happens in one part of the system will always impact other parts of the system. So our biography really becomes our biology. And this is really helpful for me to think a lot about when I'm working with an individual because you can see time in their system and you can see how the body's adapted over time to meet the demands that that organism has been attempting to do. And that's the really positive thing because our bodies are adaptable and they can shift back. So collagen is continuously laying down. Our connective tissue system and our cells are always changing and regenerating. And so even issues that have been long-standing for many, many years, I believe that we can impact and shift over time given the right environment and the right input. So that brings me to this methodology that I call Tensegrity medicine, and it's basically applying these biotensegrity concepts into more of an assessment and treatment form. And what I also am incorporating is an integration of mind-body training and looking at some of the principles around helping people change their stories and their perceptions about who they are and how they're interacting in the world, and helping people understand that they can shift a lot of that by themselves, and giving kind of the locus of control back to the patient, and understanding that a lot of how their physiology is expressing itself is a manifestation of what's happening from their internal system. So what we do is we do different kinds of assessments, and the different principles that we have with the system is, as I mentioned, that our body is whole and complete. There's nothing to fix. There's nothing wrong with you. And that's a really interesting thing to get away from, because spending 32 years in allopathic healthcare, it was all about finding the problem and finding what was wrong with the patient. And instead, I find it much more successful to come from a place of wholeness and then just find out how patterns have been developed that can be removed in a way and replaced with new patterns that are going to be much more adaptable in nature. So we function as a whole unit. Now, symmetry is a myth, and so this is again where I veer off from the traditional chiropractic, osteopathic, physio world, and I believe that having leg length discrepancies or sacral torsions or twists in the trunk or those things are not necessarily a negative thing. Those are just adaptive patterns that have occurred in the system for that person to function, and so they may or may not be something that we need to take away. The site of pain is rarely the site of treatment, and that I know sounds really radical, but I often describe it as a victim and a criminal. You come in for the victim because it's screaming and it's hurting, but often the location of the treatment is actually latent, and we find it through different kinds of assessment. So we're always looking at this continuity of the relational tension and compression, and looking at the relationship of the body and the mind. So I very much, with my dialoguing, make sure that the individual is recognized for the survival strategies that they've incorporated. And so it's very much about creating safety, like I said, with the patient, and just understanding that adaptive patterns work until they don't anymore, and that perhaps this situation is informing you that your adaptive patterns are no longer serving you. And so let's explore new adaptive patterns that might be helpful for you to be able to evolve as an individual. Now, with our hands-on interventions, what I emphasize is that we're very minimal in our treatment techniques. So I spent many years learning techniques that were really heavy-handed and are heavy-elbowed. And what I came to realize is that when I started to understand the nervous system and the connective tissue system better, I recognized that the lighter touch is much more effective. And it's much more respectful for the nervous system, and it's not as threatening to the nervous system. And I get much better and longer lasting changes in the structure and the overall pattern change when I approach it with much lighter techniques. So you Reiki therapists and craniosacral therapists already know that. All right, so these stagnation patterns that we develop in our system, I believe that they're because of maybe unresolved emotions or unresolved patterns that our system maybe wasn't able to face at different times. They could also just be that we learned how to compensate in our physical structure because it was easier, and so we just never went back to our other pattern. But it's going back and revisiting some of that to be able to kind of come out the other side. So awareness is a big piece for me in helping people recognize their patterns and then be able to shift them when they're ready. I believe that these stagnation patterns are not something that I want to force change. So like I said, I'm not there to fix anybody and to make a change and make their pain go away. but it's more an invitation of how could we maybe try something different if you feel like you're ready, and then helping people have the coping mechanisms to be able to do that. So when, again, the locus of control is given back to the patient and I'm serving more of a supportive role and not a fixer role, I find that the client comes up with their own ideas about resolution and their own lifestyle habits that are going to serve them better. So our bodies will always create primary restrictions around stagnation patterns that they're maybe not ready to deal with, and so I would never go into something that a client is not prepped to release. And so the techniques are based on a very superficial to deep kind of approach, superficial in the connective tissue system as well as the emotional system, and we move very slowly and respectfully based on what the client's able to change physiologically and emotionally and cognitively. And it's very interesting because if you change the physical structure, then patients will come in and say things like, I just feel better. I find that I'm not as depressed, or there's just this lightness to my psyche that I didn't, do you think that's related? Or, there'll be shifts in sensitivities, environmental sensitivities, or there'll be shifts in their hormone regulation and their endocrine function. And so it's a systemic change that occurs through the structure. And that's very exciting to me because that means we're not just putting on a Band-Aid, just like many other treatment approaches that we have of making somebody feel temporarily better. So assessment is a big piece. We need to make sure we find the right area to treat. And like I said, if it's not the area of pain, then it really requires us to be detectives and to find the location of dysfunction. And we do all different kinds of assessments to do that are very specifically based on these myofascial kinetic chains. And it may be related to old injuries. So we do a very thorough medical history, and the history is not just about their physical traumas, but whatever the patient's willing to share is about, is there anything in your history that might have changed your function or your form or your overall system? All right, so we talked about our goal is really to three-dimensionally balance the body. It's not to create symmetry and it's not to fix anybody, but instead to create more balance, that there's more resiliency in the structure. So we may do things like look at their specific structure in relation to gravity, see how they're positioning themselves in gravity. We may ask them to do different kinds of functional assessment to see how they can move and how they can stabilize themselves, as well as have mobility in different areas. And where are they compensating to be able to do those things? So this can be really interesting in a gym and watching different people. We do very specific testing that is local but also global. So in this case, I'm testing an individual's whole arm line all the way from the neck down to the fingers and looking specifically where I'm picking up restriction. I can then get very specific of targeting where the tightness is based on taking components of that out and putting them on slack versus putting them on stretch. We can look at global assessments. This is an assessment of the paraspinals of the back and looking at what happens with the flexion of the back and standing versus what happens when we take the legs out of the picture. And for many, many patients, you take the legs out of the picture and they get much more spinal flexion. And so that tells me that the treatment's not going to be in the back. It needs to be in the legs. So I would then go down into the legs and look specifically, which hamstring is it, which gastroc is it, which area is it that's tethering the back down to make it not be able to be mobile. And this makes my treatments much more efficient and effective because I'm not treating areas that I don't need to treat. So every client has a unique presentation. It's really interesting because you can have 10 people who come in with low back pain, and all 10 of them might get slightly different treatments based on the assessment. So that's where it becomes very challenging from a research standpoint, because we can't just lump together these ICD-10 codes of low back pain and do the same thing on all of them and say if our treatment's effective. Because where your low back pain may be coming from is maybe your old ankle injury, but it could also have something to do with that neck or the shoulder or isolated at the back. So, like I said, we approach the body very respectfully in a light touch nature, targeting these seams of connective tissue. And we're looking at what the impact is when we touch one part of the body, how it affects the rest of the system. So it's kind of unique in that I'll work on a patient and I'll have them get up and I have them walk backwards. And I have them walk backwards to not allow them to find their old pattern of movement, but it's kind of this unique, novel way of moving. And I just look at the coordinated pattern of what they're doing in gravity. So I have them do that for a while, and then I have them walk forward again and notice how the treatment on a particular region of the body might have affected the rest of the body. And usually the patient can dialogue through that walking and reveal a lot of things that are occurring. And that's where we focus on the interoception and proprioception to have them become very aware of what's happening in their system. So our tool that we use, the manual therapy tools, are very varied based on what the client's stagnation pattern is in their system and what needs to be shifted and how it needs to be shifted. So we have some techniques that use things like Bowen therapy that is very light touch in nature. Other tools that I use are using reciprocal kinds of movement patterns while we're stimulating a ligament, or we have done some kind of joint compression or distraction. And this again is teaching the nervous system how to isolate and move certain body parts to be able to get those tissues to glide away from each other. Some of the treatment interventions are more structurally based, so we might go in there and do more specific manual therapy to try to free certain seams from each other. So just depends on the person and what their system is needing. But we always integrate it through the rest of the system and then send the patient home with movement exercises, as well as I usually send them home with some kind of lifestyle change home exercise. So that might include things like meditation. That might include things like journaling. It might include things about recognizing your story that you tell yourself, and or how can you find some more contemplative time in your life, or can we have more awareness when we're walking, just depending on the individual and what they need. So this is a technique of using Bowen therapy on the hamstrings. So we're working specifically right at the origin point. I know it looks aggressive, but it's actually more light touch in nature. This is me using the inguinal ligament and the medial collateral ligament and imposing movement, specific movement to change the tension of the ITB TFL. So the clients can stay clothed. They don't need to be undressed to do this. They can be in any position. I can have them in standing or side lying or sitting, just depending on what their circumstances are. I'm using patellar ligament to release a gastroc here, and I'm using the sternoclavicular and corticoclavicular to work on the pectoralis. And then we are ending with doing more cranial kind of work up into the head for relaxation. So our goal in therapy is not the traditional goal that we think a lot about when we're doing physical and occupational therapy. It's not about taking away the pain. Instead, I use pain as a barometer to help the individual identify the stagnation patterns that their body is sending them as messages that there needs to be a shift for them to occur in their lifestyle or their overall way of being. And so we're not having a war on pain. Our pain is actually our friend, and it's helping inform us that there needs to be a shift in our life, in our lifestyle, and you know what's happening. So that means that me as a practitioner, I need to make sure that I'm not trying to take away pain prematurely, but I want to help guide and facilitate that patient towards resolution that they can find on their own, and I can help them. So really, I think so much about it is how we are showing up as clinicians and how we are creating this safe, compassionate environment where there is the ability to heal, and there is time to heal, and there's a resource of an individual that can help facilitate that. And in healthcare, I know that's really hard to find because we all feel so rushed. But I feel quite strongly that just our presence and our listening is probably the biggest tool that we have. So in my trainings, I spend a lot of time training the trainers, and we spend a lot of time looking at our own internal ecosystem and how we can shift that to show up and be the best tool for our patients. So I do a lot of curiosity questions, is what I call them in a session. I'm not doing counseling. I'm not here to give advice. I'm not here to tell the patient what to do. Instead, I just help them understand how their thoughts are really just conscious beliefs that are based on their perceptions, and that those thoughts that are based on these desires or experiences can then create beliefs that we're having. And it's our interpretations of these perceptions that are creating our beliefs, and that creates meaning out of what we see in our world. So it's helpful to examine those and to be willing to look at them perhaps a different way. And that our feelings are subjective experiences that are based on these perceptions. And there's nothing wrong as far as there's not any bad feelings and good feelings. And so I look very carefully, and I'm very careful in my training of my students to look at our languaging and make sure that there's no bad feelings. But that our sensations are just reflecting some of these issues, and that our sensations can inform us. So teaching patients how to pay attention to sensations, not just as pain, but how can we look at all sensations and how it can inform us. We do a lot of movement training, so that's involving integration through the whole system, as I mentioned. We are addressing each unique pattern for the individual. So each individual exercise program is based on what we found in the assessment. And so not every low back patient will get the same stretch. It'll be based on where their dysfunction showed up, and then how it can be integrated through the system. And so when people are moving, it's really, really important that they're not checking out. They don't have their headphones on, they're not reading a magazine. Like, they have to be present to, one of my colleagues used to say, you must be present to win. And it's true. If you can't experience it in your system, then you're never going to be able to form that new habitual pattern. And of course, it's always going to relate back to functional movement. So they're global exercises. Some of them might look like yoga asanas, some may look like Tai Chi moves, but anything that is going to be incorporating head to toe and be able to get the global system to open up. So the ultimate goal of therapy is to help the individual really reconnect with the highest potential that they have inside of themselves, and help create awareness of the barriers that maybe have interfered with their ability to evolve and to achieve their whole human potential. And it's really to empower the patient to understand that they're already whole and complete, that there's nothing wrong and there's nothing to fix, and that we can help them regain resiliency and agency within their structure, or within their structure. So thank you so much for coming, and I'm happy to answer any questions that you might have.
I actually have a few questions.
Please.
You were talking about the hyaluronic acid,
Yeah.
HA. In absence of that, is there a presence of another substance that kind of fills the void? Or are we not sure about that? Or
Well, the biggest areas of hyaluronin is actually what it is. It's also called hyaluronic acid, but it's not an acid, so hyaluronin, or HA, yeah. They find it that it's in its most dense form at the retinaculi. So the retinaculi around the ankles, around the wrists, and then it's also between structures that need to glide together a lot. I believe that the inflammatory process changes the pH of the hyaluronin, and when there's a systemic inflammation that's occurring in the body, then that's where we start to have problems.
does that chemical change result in a different chemical that has different properties?
I think it'll become more viscous, and it'll create more densification in the structure. I don't think it's replaced by another substance. I think it just changes its viscosity.
Okay.
Yeah.
The other thing is, I was just thinking about what you were saying in dissection, and I remember I had this wonderful professor, and he saw that he wanted us to identify the mesentery, right, within all of the bowel system. And he said, who volunteers to dissect the mesentery, meaning untwist the mesentery and let's look at it in its wholeness. And I volunteered to do that. And when I got finished with it, I held it up. And when I held it up, the bowel was beautifully displayed, kind of within this perfect sheet of material. I mean, it had holes in it, and the holes represented the parts that were connected, but I wasn't sure how they were connected. And like you were saying, when you're working with a knife, to be able to understand in which direction to cut, to honor its unfolding, right? And then I started thinking about how that would relate to how a person processes food, how a person then gets their energy, how a person then processes water, you know, all of these different things within the system, and then relating it back to the muscular system. It was, I mean, I feel like that in itself kind of made a connection to what, I guess, the point you were trying to make.
Yeah. So I really like the idea from an embryologic model that we are actually just folded within ourselves. We're folds within folds within folds. And so for us to understand all those folds, we have, you know, artificially made separations with the scalpel and then put a label on those things. But yeah, it's really cool. I have a couple spots available for my dissection class at the end of June, if any of you want to come to Boulder. It'll be fun.
It's been a long time since I've touched a scalpel.
Yeah, I know.
So you could actually see those, what did you call them, chains, when you're dissecting.
I mean, it's
Is
so
it clear?
cool. Yeah, so the first dissection I went to, we actually took out each of these things called the anatomy trains, if you know the anatomy train lines, and we dissected them out as individual units, and we did it over 5 days. And so we would lay them out one at a time, so at the end of 5 days you could see the continuity. So there's one on the back that goes from the bottom of the foot, comes all the way up the back and goes to the front of the scalp. So that was taken off as one continuous piece. There's one on the front that does the same, that goes through the SCMs to the mastoid process. And then there's 2 on the sides. There's arm
Do they
lines.
overlap? I mean, how could you tell?
The fibers, the fascial fibers are continuous, and they are continuous where one muscle stops at like a joint and then another muscle starts. The fascial fibers are continuous. And the fascial fibers, what the researchers are really recognizing now is that the fascial fibers are inserting into the muscles, and the muscles are inserting into the fascial fibers. So when we say there's an origin and an insertion of a muscle, they're saying at least 30% of the muscle fibers are inserting into the fascia of the next structure. So if that's true, then our force transmission is happening through the fascia. It's not happening through the isolated contraction of the muscle.
And you talked about that HA and what we thought might cause dysfunction, inflammation.
Yeah.
Why in a particular place, or is it systematic all throughout?
Well, it depends on the person, but you can have somebody who has a chronic inflammatory process that's perhaps happening in one region of the body, and then the body will always be producing, it's an inflammatory state systemically. Or like our colleague who just hurt her back a couple weeks ago, she's got an inflammatory process that's happening here, and so all of the layers of muscles that are having to go in different directions in the low back are getting more densified and more stuck together because they can't independently glide at each other because there's too much fluid tension within the structure. So that's where like food can be really, really important. We undervalue the importance of food when it comes to our health, and that processed foods and that kind of thing can really impact our connective tissue. So that's kind of one of my first home programs is let's look at your food and what you're eating and what you're drinking and how much you're moving. Like motion is lotion, you have to move for these things to get better.
And the structural dysfunction that you talked about, you touched on a little bit, maybe emotional things, but is it always, what's the genesis of that? Is it structural? I think you would say maybe that it's something else, and then the structural is a manifestation.
Isn't that
of it.
interesting? Yeah, it's a chicken and the egg thing, isn't it?
Well, it's like depression.
Right.
You have different, what causes depression? You have circadian changes, or that sort of thing. What comes first?
Right. It is interesting, but that's where it's also bi-directional in the treatment approach. So if I have somebody come in like this, and they're here to see me for their neck pain, if I don't address some of those issues that are related to about the emotional posture of this, then it doesn't matter how much I do on their neck, the neck is going to continue to be impaired. But if I work on their structure and I get their structure to be organized like this, and then we start to have dialogue about depression or whatever, it's really hard to be depressed when you're like this. It's much easier to be depressed when you're like this. So they just go together. I found typically with my chronic pain patients especially, that after people are, let's say you got a car accident or you fell off your bike or something, you have an acute injury. There's a normal healing process that should occur with that. And we should know that after we've had the body sending in repair mechanisms, and that localized inflammation is kind of run its course, and you've gotten full range of motion, that then it should be resolved. But if you have an injury that doesn't resolve and it continues and continues and continues, and you come to my clinic a year later, and then I start to wonder, is there something else that's contributing? And I have to start to look at these other components.
I have one more question.
Yes.
It's probably way too simplistic, but I like to think of things along a continuum. And if you're thinking about kind of light touch therapies along a continuum, there's one side of the continuum that is you touch, you follow, you listen, and then there's kind of this middle of the road that is like you are a presence there that kind of holds them in it, because it holds them where they are, and then you have this kind of far end of the continuum that you're leading them in a direction. Where would you put Tensegrity along there? I know that you said there's a variety of different interventions, so I don't know if that's answerable, but.
No, it's a good question. It depends on the person. So if an individual system needs to fold in on itself and it needs to be brought more into their pattern, then we will do more of an indirect technique and put them in a position of ease, so their nervous system can then let go. And then there'll be a rebound where then they can go and go the other direction. But I would never, with those individuals whose nervous system is hyper aroused, I would never try to put them into a forceful position or a forceful technique.
Okay.
Now others who their nervous system is not an issue and it's actually something's just kind of really stuck, then I may go in a more direct technique and maybe more like, let's nudge you in this direction. So it depends on the person. Yeah. So I kind of look at the Tensegrity medicine as like a toolbox, and the methodology and the assessment part is, but I have different tools in the toolbox that are going to help me based on how that system is showing up at that day, on that day. And some days, an individual will need one thing, and the next day they'll need something else, and I am happy to have a lot of different tools to be able to provide. Yes.
Not sure if it's totally formulated yet in my head, bear with me, but I guess I'm curious to hear a little bit more about the addressing like the emotional or the stories that people have. And you said like you're not doing counseling, and it's like being somebody kind of at the beginning of this path too, like coming from a family that had a lot of psychotherapists in it as well as massage therapists, and trying to decide like knowing instinctually that they're connected.
Yeah.
But yeah, can you just speak a little bit more into how are you preparing the people you're training to deal with both, and maybe even a little bit about like the licensure or what kind of that stuff.
Yeah, it's important. Yeah, so I think the big difference is that I'm not, like I said, I'm not giving advice to the patient, and I'm not informing them on what they should do. I'm helping them raise their awareness of their patterns. So there's a lot of what if questions. There's a lot of invitations to perhaps perceive something in a different way. And how would your life be different if you perceived this in this way? What would shift for you? So it might be a little more around coaching, like more of a coaching kind of approach. But I find that when I do it that way, the patients arrive at their own solutions, and they arrive at their own awareness around their issues. And then once they have that awareness, then I help them establish lifestyle habits and home exercises that could help reinforce a new pattern. So how would you feel if you walked into your office today, now that we've released your upper body and you're wide open and your heart, you're leading with your heart, could you show up at your office today like that? And people are like, no, my boss is a jerk, I can't. So it's like teaching people how they can down-regulate, and they can go in and have ways to protect themselves with their physical structure. But then they can know that in other relationships that they can show up open-hearted, and now they have a space to do that. And how would that shift their life if they knew that they could turn the volume up and down? So they can be kind of huge for people in a lot of ways, but they can be very subtle and multiple, so they kind of add up on themselves.
Yeah.
Maybe my students could even answer that better, I don't know. What's your experience been around learning dialoguing?
What you said one time, where you just keep the client in their body, and then whatever they say, you just kind of take that as a thread. So if they describe like a fluttering that's happening in their back, does it have a color? What does it feel like? What would it say to you? And you just, you keep them in their body, and whatever they say, trying to do some reflective listening so that you're receiving what they're saying, but you're not telling them, oh, this is what I think that probably is. So it's a skill. It's hard. It's definitely something to be trained.
I would say that it's, I will say for all of the students in our class, it's been the hardest part so far. I am more comfortable with it than I am with the physical part, because I had probably done more of that in my experience. And I have heard from a lot of people in class about how difficult and how uncomfortable it is for them. But we have practiced a lot, and we're just on day 5 out of 24 of days over the next 2 years that we will spend with Kelly working on it. And I think it gets easier and easier. And it's just a process really of learning to listen and to stay centered in yourself, and hear their story for them and reflect it back to them. So it doesn't really require a counseling degree to do that. It's just about being a good listener, and anybody can do that.
And from an OT perspective, I call it higher level ADLs. So that's how I bill it.
Sorry, higher level what?
ADLs, activities of daily living.
Okay.
It's just to put on something from the neuroscience world. When a true therapist will actually never really tell you what to do, because if you tell somebody what to do, their subconscious has not released the answer. Their real job is to kind of direct the patient. I always tell patients, like, they'll tell you, are you going hot, 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 hot? We'll let you keep talking. But if you're going way cold away from where we know the problem is, they will redirect you into the direction and into the issues that they think are kind of the problem. So in all reality, when we're doing any kind of counseling, you want the patient to come up with the answer. Because if the patient doesn't come up with the answer, it never leads to real change or real release of anxiety or release of depression.
Can I ask one follow-up question?
Please.
So would you say in this Tensegrity model, to me it sounds like you're kind of coming more from the body, like the physical realm, letting that lead into the emotional stories versus the other way?
In this particular setting, yes, because people come to me for their physical problems.
It makes me think of Rita Sharon at Columbia University has a degree in narrative medicine,
Yeah, yeah,
and it's about helping the patients find their story,
yeah.
their individual story of identity, their story of illness and their story of healing, and then kind of melding those into an individual story that becomes the treatment plan, and that the practitioner, whatever level practitioner it is, then guides them in, it's like helping them through their creative writing process. And then the practitioner actually also has to journal themselves in the form of notes to be able to say, and this is where we got, this is what part of the story we got to. And then also self-reflect and say, and that's made me a better practitioner because, right? So it's like a big, huge continuum of this narrative, which is kind of where I feel like medicine should go.
Yeah, it's very person-centered, and so that's why it can't be evidence-based. That's where it's really tricky. And yeah, journaling is a big part of it. I actually have, that's one of my big home exercise program usually starts with journaling. There's a lot of good research coming out now too, with a lot of different chronic pain specialists with that and using journaling and
And
writing.
she does, there's a lot of research articles that she's doing, especially about end-of-life care and pain management with cancer and these long-term illnesses. So, and a lot of like really evidence-based, good, positive results.
Yeah,
So
that's great.
it bodes well for all of the healing arts, I feel. Because it is considered a humanity of medicine, which is kind of where we're moving, right? It's the art of medicine.
Hopefully.
Yes.
That's why we're all here.
Yeah.
Yeah, thank you.
What role does intuition play in this? I think sort of maybe following up on what Neil was asking. I know it sounds like there's a lot of clinical observation and diagnosis to a degree, but could you speak a little bit about the role that intuition plays?
Yeah, it's kind of interesting because I think it's, in the training I teach the students really basic research-based assessment and treatment techniques. And once they get all that down, then I'm like, throw that all away. And that when you come into a session, you actually I have no idea what I'm gonna do in a session. You know, I don't have a plan because I show up and I'll know the plan based on what the individual is telling me. So that's where the art comes in.
Yeah.
Yeah.
So I don't call that art, I call that way of being.
Yeah,
So your knowledge matters this much.
yeah.
And what gave me chills when you said, I come to my patients as if they are whole and complete.
Yeah.
That right there probably heals most of your patients.
I
Nothing
agree
else
with
they
you
do.
because I see them that way until they can see it for themselves.
Yeah.
So I hold the space until they can recognize it for themselves, and then I just support them.
It's just so beautiful. Like everything you said is so on for me.
Thank you. Thank you.
It is the most beautiful part when you can only heal yourself. It's already in you. And so if you're just holding space for that person to become aware of that, that is this stuff.
Well, I mean, I think we are, those of you who are healthcare providers, we came into our profession to really help people, and I think what I've discovered with this work is that I feel like I'm really helping people at kind of a soul level. That's why I love being here. And that is soul therapy, I think, that I'm not just dealing with the superficial stuff or the manifestation of it, I'm actually getting to the root issues and helping the person discover those and then to find their own healing that they find for themselves. So I get out of the way as much as I can, you know? That's more important than me doing anything to them.
I have another question. Do you find sometimes that on one end people might like be resistant to going to the emotional side? When you start asking questions, or do you have people who come to you with primarily emotional issues, ever rather than physical?
I've had both of those. And that's where, again, the art comes in, because if you're, let's just use we both, in Seattle and Charleston, you both have Boeing people, right? That work here at Boeing. And so I see a lot of like engineer type people, that are very analytic and logical. And with those patients, as well as any patient who comes into my room, I'm always gonna be very understanding of how can I relay this information to them in a way that they're gonna hear me. And so it requires me to be a little bit of a chameleon in my approach. So I'm using language that they can understand and that they can integrate. And so it's all about semantics that way, and then how you're presenting it, and when is the timing to talk about some of these things. And often it's not in the first session, right? Because they're coming to me for their rotator cuff injury. They're not coming to me for the emotional, right? But as I gain trust and I gain the safety, and they start to notice that there's some changes happening in their system, then we can kind of lead them in that direction if it's required. And the same with the emotional. I believe that just tapping into the physical structure is creating safety and support, and that it starts the trajectory.
How do you define your length of a session? If you're really in there and the client is responding and you're making lots of progress, how do you humanely and appropriately phase into the end of that session when lots is going on?
Well, I
To
always
keep a schedule.
Yeah, that's right. The next person.
Yeah.
I always remember that I'm in charge of the session. It's my role and responsibility to make sure that there's a bell-shaped curve that goes to the session. So we're doing the intake, we're checking in, we're doing the assessment, we're starting the treatment, we're getting to the intensity of the treatment, and it's my role to know when to start winding it down, and then how to facilitate an endpoint that doesn't leave them hanging. So yeah, I guess it's just experience of knowing how to encourage that closure to happen and to leave them resourced. So I always make sure at the end of the session that they feel empowered and they've got something that they can go home and do to keep the empowerment. And one of my big phrases is, can I hold you accountable to performing this activity that we both agreed upon until I see you next time? And usually what their home exercise program is what they decided they can do. So I may say, what would it be like for you to meditate or to have a contemplative practice every morning and spend 15 to 20 minutes in stillness and quiet? And I can have a patient say, well, that's ridiculous. I can't do that. I've got a job, 3 kids, blah, blah, blah. And I'll say, well, what could you do? So it's, again, the coaching part of it. I think I could do that twice a week after my kids go to school. Okay, can I hold you accountable for that? What I'm gonna do is I'm actually gonna give you a calendar, and we're gonna write that down as a home exercise program, and you're gonna check the boxes when you do it. And when you come back next time, we'll use that as a sounding board that we can then move on and find out how that impacted your physical symptoms and your, how you're feeling. So I'm a cheerleader and a coach in a way, but I'm directing them, but they're making the decision about how it happens.
I guess I ask that because with massage, you can elect, if you know that you haven't been in a long time, which I haven't and I adore and used to go at least once a week, if not more. You can elect to do a 60 minutes or a 30-minute session all the way to a 90-minute session. Do you vary that with your clients based on need and that dialogue?
Yeah, when I see somebody, I usually see them for an hour and a half to start with.
Okay.
That way I really get a sense of who they are. I can do some treatment, I can see how they respond. Now, if they're under an insurance model and I'm working in that capacity, then I just do with what I can. I work within an hour or 45 minutes and just make the evaluation over 2 sessions. But after that, then I'll say, optimally, I think if we could see each other for another 90-minute session, that'd be great. Or your issue seems to be fairly resolvable and you responded to your treatment so quickly, I think I could see you in a 60 minutes. So I'm kind of deciding that based on what I'm seeing. And once people start to have the shift occur in their system and they start to make changes, often when they come back, they just need a little bit of tweaking. Like, it doesn't take much. I could get down to a 30-minute session and it's easy. But it helps them continue the movement in the right direction. Yeah? Good? All right, well, I'm really happy you came. My website's kellyclancy.com if you want to look up any of my classes. I've got online classes and in-person classes. I'm thinking about maybe doing a second mentorship here in the Charleston area, if anybody would be potentially interested in that. And if you are, I just have a piece of paper over there. You can just put your email down. I also come and do 2-day workshops or 1-day workshops. Would be happy to do that as well. So thank you again.
Thank you.
Thank you.